So I'm just going to go through the kind of the slightly more down-to-earth modalities that are used for delivery of these therapies. So I'm going to run through one you'll be very familiar with, X-ray filming, otherwise known as fluoroscopy, and just show you things that we can take out, things that we can put in, and use it as guidance for sclerosance, so chemical cautery, as opposed to thermal cautery, and we can aspirate things in the Samuel Schempp way. So I thought, by way of, this may or may not be entertaining, and I have a feeling it's not going to be. Oh, how disappointing. That was supposed to be a film. Any chance you could sort of work on that? I'll press on. There's a film on that in the file. The wrong way round. But imagine that was the right way round. This is an IVC filter. This is how you get them out. So it's in the IVC behind your abdomen, and you lasso it from above. It's like one of those sort of fairground games. Oh, and there we go. And it's gone, and you get a teddy bear. Okay. This is, and this one please, I have no idea which direction this is going to go. Oh, here it comes. This is putting stuff in, so we've taken a piece of metal out with the other one, and this is putting coils in. This is something you may not be familiar with, but pelvic varicose veins, pelvic congestion or whatever. You see the Valsalva put the coils in, and that is a source of distress to a lot, mostly of post-pregnant women. You put a coil in, again under fluoro guidance. That's the Valsalva, put in the coil, and now when she Valsalvas, no reflux, no varicose veins in the legs, no hemorrhoids, no premenstrual tension. Let's talk about cancer. This is something that Colin brought to me some years ago, the concept of carotid blowout, when you get secondary head and neck cancers growing back, and you can see on the CT scan that the carotid artery now is exposed on the surface, and when that blows out, it's a terrible, terrible experience, obviously for the patient, though rather short-lived, and for the relatives, a permanent trauma, which is quite appalling. So we thought we would do something about it, and using fluoroscopic methods, we can place covered stent grafts to line the artery to at least make it safe, and they can go on and have further radiotherapy or photodynamic therapy, but they're not going to blow out. And we've developed them, I think we've got the largest series, certainly in Europe, on that, and it's very successful, very low risk. Look, there it is, there's the stent now, exposed on the surface. Arteriovenous malformation's got a mention, if you could play that one. This is by way of using it to inject into a very troublesome cancer type. I know they're not an official cancer, but they certainly behave like it. This is somebody's face, this massive arteriovenous fistulation, and then you can see we're injecting alcohol, trying to find the arteriovenous nidus, the transformation. Just give me a couple more moments. You see it's still flowing, flowing, flowing. It's all a bit sped up, obviously it takes all afternoon. There we go, and now it's gone. You just have to find the right place. So, but that's a high flow, this is a low flow. Again, it's like a benign tumour, but again, you can find the nidus needle directly in under fluoro guidance, sclerose it under X-ray vision, and she's very happy about that. So I don't want to steal any of Simon's thunder, but this is how I got involved with this, using ultrasound guidance. We've moved on from fluoro to ultrasound modality, which is very flexible in terms of access to the patient. There's no radiation, you're right on it, if it's reasonably superficial. This is PDTing a neck tumour. You'll get much more of this from Simon than me. I think we were both involved in this. All the different modalities have their strengths and weaknesses, and sometimes you want to take the strengths of one modality and use it with the flexibility and the ease of access of another. And this is an example of taking information from MR and fusing it with an ultrasound image, in this case in the prostate, because clearly you're not going to see that little area that shone so nicely on the MR, but now you can get your landmarks in the one using the ultrasound, which is much more useful in the interventional suite. And similarly, using the best of ultrasound with the enhanced CT. The trouble with CT is fantastic visual acuity, but the best results are seen with enhancement, and of course that's not happening while you're in the scanning. You just see the greyness. You lose the soft tissue definition. But CT is fabulous where there is natural soft tissue definition, such as in the lungs. You can see here there's a couple of colorectal metastases that have been already resected. That's just sort of made a bit of a mess, but there's still these things. And so it was sent for microwave, just another form of heating and ablation, but you've got to get the needle in. So here's a whole series. You follow it down, you can see the white stick is the needle, approaching the metastasis, skewering it, treating it, and a few months later you're left with now a resolving scar. And it's all beautifully shown because of the natural tissue contrast between the air and the tumour in the lung. So CT is fabulous because you can really work at it. It has, you can measure things and you can plan your attack if you want to treat large volumes. It would be wonderful if you could do it robotically with templates, though that's very difficult because again people tend to move, but you can do it in real time here. Clearly the plan would be to have a plastic template or whatever, and it's all pre-planned. I want to talk about MR intervention. Why would you bother with MR intervention? Because it has high soft tissue contrast without having to use gadolinium. The trouble of it is, and there's far more troubles than there are positives with it, is safety. You're a long way from the patient who's in the tube. It's highly magnetic, so if you're using metal needles, you get a lot of artifact, and if you let go, things can sort of fly around like an Indiana Jones movie. And you've got to be careful to take your wallet out first, or it'll wipe your cards. And the sequences are long and slow, but the ones that are fast are not very visually, they don't show you much definition. So what happens if you use non-metallic needles which pass less artifact? One thing, bone. We've said that CT is good for showing bone, ultrasound is not, MR traditionally is not, but the group in Oxford have been developing the definite bone, black bone definition on MR, so that's overcoming one of the many disadvantages of MR, such that it can come into its own. So one of the little experiments we did, and this is by way of finishing in case Simon's getting anxious, is to use non-metallic needles. What if we use non-metallic needles? Because then the field strength wouldn't matter. So we experimented, and this was back in the National Medical Laser Centre days. Sandy, Colin, it's nice to see everybody again actually. So we tried with various substances, various materials, settling on carbon fibre, developing out of a chat about fishing rods, and using tiny fishing rods, using a metallic mandrel to get the thing into the lesion percutaneously, and then taking the metal away and only leaving the carbon fibre. Would that work? So we tried it out on the experiments we were doing, or the trials we were doing at the time, with MR fetal autopsy. Why was it interesting for that? Because autopsy in MR is fabulous, particularly for for fetuses which become very decomposed very quickly. And if you could combine that with the ability to do biopsy, would that not be a fantastic alternative to classical autopsy? And then we were using it in adult liver metastasis, thermal ablation, because that's one of the things we were doing. Let's see what it looks like. These are the needles. They look rather attractive in their dark grey matte finish, the Luer lock glued onto the end, and the mandrill borrowed from another needle. Now we tried them out. Usually you do it on farmyard animals, but we hadn't got that far. So we used the fruit bowl instead. This is what it looks like in a grapefruit. This is the metallic MR compatible needle, which is mostly nitinol and titanium, but there's a little bit of iron in it, and you can see it's like shoving a cigar in. How accurate is that? And these two other needles were little carbon fibre needles, which are fairly representative of the size of them. They're a cross section. If it's good enough for a grapefruit, what about pineapple? Pineapple, what can I say? And you can see you get a very accurate representation of a needle. So it can work for that. We'll come back to that in a minute. So what about using it for real? Here's a fetal autopsy. There's a cross section of the abdomen, actually the liver. Here comes the needle. Just by way of showing feasibility. There it is with another angle, one of the advantages of MRI. Can you see where we are? Okay. So here we are in the adult, doing it for liver ablation, using gradient echo sequence. You can see it's very poor acuity. But there's the needle clearly shown. It's one of those little needles you saw. And there it is after the thermal ablation of that right lobe tumour. So, conclusion. There's a range of modalities available to us which can be used for adjunctive supportive procedures and also in the treatment of solid tumours. Ultrasound remains the most flexible, versatile image guidance modality, but perhaps now with some ability to fuse the benefits of CT and MR. CT, we've talked about the pros and cons for deep structures, bone and lung. And MRI remains a hopeful challenge, but there's always the promise of new developments. Over to Simon. Thank you very much.